Good morning, everybody. Very nice of you for all of you to come out. Actually, as I look through the room, I see a lot of familiar faces, our industry partners, our patients, and colleagues. And it's we all have a common problem, obviously. And the only way to solve some of these problems is to partner up. And I think these type of sessions is where we actually get everybody together. And we do need patient input so that we know where to go also. So glad to see everybody here. So we're going to start off the first session with diagnosis and treatment with one of our very own, Dr. Juan Rivera. He's an associate professor at McGill University in endocrinology. It's okay, I promoted you today. It's okay. And he'll be talking about, before you can talk about anything, you actually got to classify it. That's what they keep telling me. So we're going to have Juan classify neuroendocrine tumors for us. Juan.
Morning. Thank you, Dr. Metrakos, for the introduction. So, yes, typically the first talk in this type of conference deals with very basic matters. So we're going to define certain terms. And, okay. We're going to basically put everyone on the same page as the initial step in the sequence of conference that will follow. That's not it. Thank you. So the objectives of my talk today are to help you understand the basics about endocrine tumors, to understand what do we mean by neuroendocrine tumors, to understand the different classifications of this disease, and understand the importance of the pathological classifications and its implications. So we start with the very basic. As I was saying, sometimes the terms that we use in our daily practice and when we explain to patients things have a completely different connotation in the minds of the doctor than in the mind of the patient. So basically that's what I intend to do with the first few slides, to clarify these terms that sometimes could create certain confusion. So what do we know when we don't know what the meaning of a word? We check the dictionary. The Merriam-Webster dictionary defines tumor as an abnormal, benign, or malignant new growth of tissue which possesses no physiological function, and I emphasize physiological, which means not normal function, and arises from uncontrolled, usually rapid cellular proliferation, which is also called neoplasm. So notice that when we say tumors, it doesn't mean cancer. It could be benign or not cancerous. It could be malignant or cancerous. So what's cancer then? Again, the Merriam-Webster dictionary defines cancer as a malignant tumor of potentially unlimited growth that expands locally by invasion or by displacing structures around, and can also expand systemically, meaning to other places on the body through metastasis, which is basically using the bloodstream and lymphatic circulation to go to places distant from the original tumors. As I say, this is very basic. Probably most of you are clear about that, but I think it's important that we are in the same page, and this will help you for the rest of these sessions. So what's an endocrine tumor? It's a growth that affects the part of the body, of course, that produces hormones and secrete hormones. And therefore, these tumors, endocrine tumors, have the potential to produce hormone themselves and cause disease related to this hormonal production because it's non-regulated. It's usually in excess to what the body is used to see. Again, very basic. What's a hormone? You're talking about hormone. So hormones are chemical substances that are formed in specialized cells, and are carried in the bloodstream to have specific regulatory effects on the activity of other cells in distant places, usually in distant places in the body. So very important, it uses the bloodstream. The hormones usually use the bloodstream, and they travel to communicate with other cells. There are also hormones that can act to the very close, the cells that are in very close proximity, but the typical definition of hormones are those that travel through the circulation, and in that way access the target cells and have an effect, a regulatory effect on those. So finally we arrive, what's the difference between an endocrine tumor and a neuroendocrine tumor, neuroendocrine tumors, which is what we call NETs and what defines this conference. Well, these terms actually could be used interchangeable. Sometimes they are used interchangeable. But if we want to find the difference, is basically that neuroendocrine tumors are part of the endocrine tumor family of neoplasm, but they derive from a specialized type of cells, endocrine cells called, who can guess the name of the cells? Neuroendocrine cells. Does it make sense? So neuroendocrine tumors originate from neuroendocrine cells. These neuroendocrine cells are basically cells that are a cross between endocrine and nerve cells and neurons. So they have the ability to secrete hormones as endocrine cells, but also they express molecules that are typical of the nervous system. So that's why we use the term neuroendocrine cells, and the tumors that come from them are called neuroendocrine tumors. What are some of these markers of differentiation? And again, I'm going very superficial and basic here, and I don't intend to give you the whole list. There are many, but the most important that are most usually used in practice are neuron-specific enolase, which is present in the cytosol of the cells. And in the granules, we have another couple of markers that are very important. That's chromogranin A. So those are inside the cells, in these places where the cells store their secretions. Those places are called granules. So chromogranin A is stored there and is secreted, and you probably know that we can measure that in the circulation. Same thing with synactophysin is also secreted to the circulation and can be measured. So those are markers that are typical of neuroendocrine cells. So neuroendocrine tumors are tumors that originate from the neuroendocrine cells. And neuroendocrine cells are present throughout the body, from the brain to the lower abdomen and the gonads. So this is a schematic representation of all the different. Do we have a marker or a mouse? No one. Pointer? But I wouldn't be able to point here. I thought I would have a mouse, but I just. All right, no, it doesn't matter. You can see here the whole list, pituitary adenomas. So starting from the pituitary, we have neuroendocrine cells, and thank you. And the, yeah, I don't think I'll use it. I'll point to myself. So pituitary adenomas are part of the family of neuroendocrine tumors, because the pituitary cells are neuroendocrine cells. Certain type of thyroid cancer, not all of them, are also derive also from neuroendocrine cells, the parafollicular cells, and those are the medullary thyroid cancer. Parathyroid adenomas, another tumors that are in the neck, next to the thyroid, they are also neuroendocrine. Then you have the lung and thymic neuroendocrine tumors, and then the big group of gastroenteropancreatic neuroendocrine tumors. There's a long name because there is a long list of cells there, more than 15 different cell types, all of which are neuroendocrine, and they are distributed along the gastroenteropancreatic tract, and they can produce this type of tumors. Then we have the pheochromocytomas and paragangliomas, which are localized or they have their origin in the inner part of the adrenal glands and in other so-called ganglia, nerve ganglia that are distributed throughout the body, from the orbit to, again, the gonads. And then we have other less frequent prostate, ovarian, testicular, and rare neuroendocrine tumors. Also in the skin, we have this type of tumors called Merkel cell carcinomas, which are neuroendocrine. So having said that, we have to emphasize that when we refer to neuroendocrine tumors, we almost always are thinking mainly of the ones that I have highlighted here. So the lung carcinoids or neuroendocrine tumors, the thymic carcinoids, and the gastroenteropancreatic neuroendocrine tumors. The less so for pheochromocytomas and paragangliomas, but the rest are usually typically studied and treated separately, even though they share the features of endocrine tumors. And what are those features? What do these tumors have in common? So we mentioned it before. In general, they have slow growth. So the relative is slow growth. So of course, velocity, speed is a very relative term, but that's commonly accepted that these tumors grow slower than other type of neoplasm. In second place, they have a preserved hormonal regulatory pathways that allows them to respond to regulation by hormones. So because of that, they are susceptible, amenable of their growth is amenable of modulation by hormones. Also, we said it before, they have the capacity to secrete hormones that cause troubles because of these hormones secreted in excess. These tumors differ also from other tumors in the fact that from looking at the microscope, it's not easy to say when it's malignant, which one is malignant and which one is benign. It's more their behavior, the way they grow, what is going to determine what way they go. There is a lot of research trying to help us define better what, when we see the microscope, when the pathologist, and you will hear from Dr. Ramela Ari in a minute, see the tumor, what things could help predict the behavior of these tumors. But these tumors are not easy to predict in their behavior, and that's typical of them. And finally, they have poor response to conventional chemotherapy. So how can we classify these tumors again? You can classify them according to their secretory capacity or their functionality, if they're functioning or not. We can classify them according to the anatomical origin or the location, where are they located. We can classify them according to what the pathologists see on the microscope or the degree of differentiation, and we'll see more about that in a couple of minutes. So according to the secretory capacity, they are classified very easy. Either they secrete and cause problems or they don't. So functional or non-functional tumors, functioning or non-functioning tumors. Functioning or non-functioning neuroendocrine tumors. And the functioning ones, you have here some of the most frequent ones. This list on the series of Dr. Vinick focus mainly on in the group that I mentioned, the gastroenteropancreatic tumors, and you can see that the largest or the most frequent functioning tumors are those so-called carcinoid or the ones that are able to produce the carcinoid syndrome. Other tumors that are listed there, like insulinomas, pancreatic polypeptidomas, gastrinomas, bipomas, glucagonomas, and somatostenomas, they are much less frequent. So what's the carcinoid syndrome? We just mentioned it. Probably most of you or some of you may know. So I just briefly mentioned what defines the carcinoid symptoms. It's a group of symptoms that present and they have a common origin. These symptoms are basically flushing, which is basically a dry flushing, no sweating, just dry from the trunk up. Diarrhea, I circled there cramps, and wheezing. Bronchospasm causing wheezing. So those are the commonest of these manifestations, or the most, at least at present. In this series, I think it's a little bit old, and heart lesions were seen much more frequently than we see them today. You see that other symptoms and signs are also associated, like muscle disease, muscle weakness, joint pain, swelling, some dilatation of the vessels in the skin called telangiectasia, and cyanosis, which is this purplish coloration of the skin. You can have in carcinoid syndrome diarrhea and flushing in 60%. You can have diarrhea without flushing in 15% of the cases, and you can have flushing without diarrhea in 5%. So you see that some patients, some 20%, they don't have either. And this is what it looks like when you have the flushing of carcinoid, the red coloration of the face. The first two faces on your left, those are the typical carcinoid, but there is also something called the atypical carcinoid, and this is what you see on your right. and it's more like a violation. It lasts much longer, not just a few minutes, but several minutes. It's more painful. Several hours, actually, they can last. It's more painful. It's accompanied by swelling and lacrimation or tearing. So there are many other functionals, and I will not go through these because of time. We started late. I'm just going to show you that these are different symptoms that are caused by different hormones that are produced by other tumors. Most of them in the gastroenteropancreatic tract originate from the pancreas and from the small intestine. The carcinoids can originate also from the lungs and the thymus. So what's the anatomical classification? They have been classically, endocrine tumors have been classically classified as foregut, midgut, and hindgut tumors. So foreguts are from the stomach up, including the duodenum, the pancreas, the stomach itself, the lungs, and the thymus, and the bronchia. Then you have the midgut, from the duodenum to the whole small intestine, and the first portion of the colon, so the ascending colon. And then the hindgut will be the second portion of the transverse colon and the descending colon as well, up to the down to the rectum. So what's the meaning of this classification? It has certain value because certainly you see different syndromes or clinical manifestations depending on the origin, but it doesn't really define. There is not really clear cut between one and the other. I can tell you as a general rule that the foregut, the ones from the upper part of the body, they tend to cause more endocrine syndromes, so more manifestation due to hormonal excess. The midgut, they produce hormones, but the hormones are usually metabolized in the liver and they don't cause troubles unless there is liver metastasis. And the hindgut, usually, they are more silent. They rarely cause any hormonal syndrome. And finally, the degree of differentiation is the last, according to the degree of differentiation is the last classification, and there you can say they are low grade or high grade. Most neuroendocrine tumors are low grade, and note that being low grade doesn't mean that it's benign. You can have benign and malignant low grade neuroendocrine tumors. So the bottom line of this classification, there are many different parameters that are taken into account when you want to stage these tumors or differentiate whether they are benign, low-grade malignant, or high-grade malignant. But the bottom line is if there is metastasis, then there's a cancer. That's a malignant tumor. That's what defines malignancy. In the absence of metastasis, aggressive behavior can be predicted or suggested. It's never absolute, but can be suggested by the following. A tumor size more than 2 centimeters, invasion, local invasion of the tumor, an index called Ki-67 when it's more than 2%, which is a reflection of the activity of the cells in terms of the division, reproduction, or proliferation. And then the presence of certain things under the microscope, like necrosis and something called cellular atypia. And the mitotic index, when it's more than 2, again, this is what the pathologists see, counting the cells that are actively dividing. So many different societies that are dedicated to the study of this tumor have made a recommendation as to how to classify, how to report these tumors, and how to stage the patient who carries one of these tumors. Basically, staging systems go from stage 1 to stage 4, and then you can grading also grade 1 to grade 3. So the idea is to predict prognosis, predict what the behavior of the tumor will be, and the impact on the life and quality of life and survival of the person affected. So the INETS, which is the European Neuroendocrine Tumor Society, has been working on this for several years, and they keep coming with new recommendations about how to do the classification, and they give us very good guidelines as to how to do this. In their recommendation, basically, I already mentioned the importance of this staging system is that it gives you a prognostic value, or at least that's the idea. Also, it helps the doctors in terms of the therapeutic decisions that and what way these tumors should be treated. Also, so they have created this tumor, lymph nodes, and metastasis, or TNM classification. Or they have made suggestions for one classification as such, and another grading system that I already mentioned, which basically considers the activity, the proliferation activity of this tumor, mitotic count, and Ki-67. And they establish what are the minimal requirements for reporting these biopsies. So these systems are currently being validated, and we at McGill we are trying to do our own validation of these different systems that exist to grade and stage these tumors. So with that in mind, we have been reviewing biopsies reports from pathology, and we have some preliminary data to show you how things are progressing in McGill. So we reviewed and we divided those that were reported before 2004 and after 2004, since 2004, since that's the year when the second WHO classification came up, and also when the INET started to, if I'm not mistaken, to put these new proposed classifications. So that we arbitrarily divided in 2004. And basically, the idea is to see whether we can go back and stage our patients and validate their staging, this staging system. The WHO requires that the tumor reporting include size, depth, mitotic index, Ki-67, and angio invasion. The INETs, when the tumors is, there are many other parameters, but I'm going to just show you what we found with these three, which they say must be reported in their suggestions. So what you can see here is that in our hospital, there have been a great progress when you compare before 2004 and since 2004. So basically, in terms of the WHO criteria, we counted the patients that have all 5 criteria reported, at least 4, at least 3, and at least 2. And you can see that before 2004, the percentages were relatively small. But since 2004, the degree or the frequency which this has been reported is much better, up to 95%, with at least 2 of these criteria reported. In terms of the INET recommendation, 1, 2, or 3, or known, you see before 2004, we have very little reporting of those criteria. Since 2004, there has been a significant increase in the number of biopsies that meet those criteria, which Dr. Amre will tell you, doesn't mean that the pathologist is not seen. It's just that many things are assumed, and they might not be dictated because it wasn't that obvious before that information could have an impact. It could be in the management of these tumors. So I'm pretty sure Dr. Amre is going to comment more on those criteria. This is the same thing, showing the improvement that we have had. And in conclusion, we see that there has been a significant progress, at least in our institution, in terms of the quality of the reporting of our biopsies. We need, however, perhaps reporting protocols so that each one of these parameters are taken into account and clearly reported. And we must conduct our own validation process, which requires your contribution. And at this point, I would like to mention that the Pan-Canadian database is ongoing, and there will be available for those of you who want to register and give your consentment. There will be some consent forms for you to review, and if you are willing to participate in this database, you will be more than welcome to have more information about this database. And with this, I conclude. Thank you very much.